What I want to do is give us an update on telesurgery, and then we're going to talk about the new robotic systems that are out there, and I'll kind of blitz through some of this. So this is the really hot topic now in robotic surgery and telesurgery, and you're going to hear more about this. I'm going to take you through a little bit of the history and show you kind of where we are today. But these are some of the papers. Really, the charge has been led by Vip Patel down in Florida, and you can see in a number of journals there's the humanitarian aspect. We're going to talk about that, the ethical and implications, technological implications of this. This is a paper that we wrote just recently looking at robotic platforms, and not all the robotic platforms I'm going to talk about today are telesurgery capable. So that's sort of a hot topic. Which robotic systems can you use telesurgery in? And then really there's a lot of technical and ethical considerations that I'm going to go over today with you as well. So what is telesurgery? And really it's the intersection between medicine and technology. And you'll see that there's a significant humanitarian aspect to this. It has implications with surgical education and training. And we have seen applications in neurosurgery and cardiovascular surgery, but I'm going to actually take you through where we are in urology with this aspect. So the origins go back to Rick Satava. He was a general surgeon, and the funding from the DARPA project, which was a military project, funding from the government, really, and this was the roots of the intuitive Da Vinci robotic system. And his vision was to develop a telerobotic system that could be controlled by surgeons for wounded soldiers in the battlefield to stabilize them. And here's the first clinical use was Jacques Marcoux, who was a general surgeon. He performed a cholecystectomy in New York City on the left-hand panel, and the patient was in Strasbourg, France. And that was the first surgery that was done. And from that, we started to see general surgeons doing procedures up in Canada. And that was really the first significant robotic surgery procedures that were done by Dr. Anavari. So all of this started back in 1994 with a master grant in telecommunications and robotic surgery from the EAU. And at that time, the only robotic system that was available was the Zeus system. Some of you may have used this system. It was purchased by Intuitive. It was telesurgery capable, and it was the only robotic system available at that time that you could communicate with optic fibers. So the Lindbergh operation took place actually in 2001. Considerations ethically were done in May. This was actually put forward to the FDA in September, and the FDA actually refused this. So instead of having the patient in the United States and a robotic surgeon elsewhere, the parameters changed. The robotic surgeon was actually in New York, and the patient was in Strasbourg, France, and that's when President Chirac actually gave support to let this procedure take place. So the Lindbergh operation took place on September 7th, 2001. And I'll bet you not many of you heard about this operation at that time. There was a big news press conference that was scheduled after this took place, and I'll show you a little bit of the footage from the surgery. But what's interesting is the news conference was scheduled for September 11th. And because of what happened in New York City, none of this actually got dissipated in the news. And really, no one really knew about that surgeons were operating in one place versus another. So this is what the operations center looked like. Kind of reminds me when I was growing up and you would see the space shuttles taking off, all these guys on computers doing all these things. Here it took place in this building. Here's the surgeon sitting down. Here's the patient. You can see a very primitive robotic system back then. Look at the device he's using. It's a surgical hook. Really some of the early primitive work. When we did robotic surgery back when we first started doing this with the hook, we've really progressed over the years. But here you can see as the gallbladder is being done and removed. Next slide. And can you turn the sound
Una donna
up?
di 68 anni a Strasburgo.
Doctors in New York performed surgery on a patient in France.
Puis je vous le disais en titre, une première en matière médicale. Le chirurgien a opéré de New York une patiente qui se trouvait à Strasbourg.
이제 환자들은 세계 유명 의사들로부터 먼 거리에서도 수술을 받는 게 가능해졌습니다.
So you can see significant press coverage How many of you heard about it in the United States? I bet you not many. Well,
It's The Tonight Show with Jay Leno, featuring Kevin Eubanks and The Tonight Show Band. And me, I'm Ed Hall.
Hey, here's an amazing story. Here is an amazing story. Surgeons in New York City used a remote-controlled robot to remove the gallbladder of a woman in France. You following me here? From monitors, TV monitors in New York working the controls, they were able to use the robot in France to remove her gallbladder. In fact, right now, as I'm standing here, there's a doctor in Belgium checking my prostate.
so there we are. This is the press coverage that we got in the United States for this. Next slide. But really, that's paved the way from where we are in 2005. Dr. Anavari at McMaster University started doing general surgery procedures up in Canada at North Bay Hospital, which is a significant difference. And this was really, the robotic the foundation of where robotic surgery and telesurgery took place. So there was a big pause, and then in 2003, this kind of surfaced again. And this is Vip Patel in China did the first live robotic telesurgery prostatectomy using the Edge robot from Beijing to Sanya. You can see the latency was 21 milliseconds. We'll talk about that. He then was able to do a partial nephrectomy in an animal using the Medibot, and we'll talk a little bit about that, and you can see the latency that existed. So, and a couple days later, he actually used a triple console, so 3 surgeons were operating on a patient. And you can see in Beijing, Henan, and Hunan, you can see 3 different surgeons operated on one single patient in Beijing. And this was done over a 5G network, and it was using the Kangdu robot. And then now, actually in November of this past year, the first telesurgery prostatectomy was done in Africa using the Medibot. And here you can see Dr. Patel did this using in Africa, and this has really changed sort of the playing field. Now we have established that we can do this, we understand the technology. And why is telesurgery important? Well, there's clearly a health equity that exists. 310 major surgeries are performed each year. Less than 5% of these are done robotically or laparoscopically. Significant lower income nations have no access to surgical care. If you look in Africa, 97% of sub-Saharan Africans have no access to surgical care. This health equity really does exist around the country. 5 billion people don't have access to surgery. This was an article that appeared in The Lancet. And you can see, looking at health equity across the world, I was fortunate enough, I spent a year working for the World Health Organization, and I worked in Pakistan developing health programs. And you can see the inequities in Switzerland. They spend 700 times more than what's spent in Madagascar. In Pakistan, the government spends 15 cents per person per year for healthcare support. There's also a lack of trained medical professionals. 18 million professionals are needed to provide healthcare coverage by 2030. Over 100 million people are in extreme poverty, and you can see that a significant 950 million people spend at least 10% of their income on healthcare expenses. Here's the United States. You think we're a developed country. The dark green represents areas where the most uninsured people are. You can see swaths in Florida, Georgia, Texas, and then when you get to New Mexico and Nevada, there are significant areas around the world and around our country that have no access to health care. So the real challenge with telesurgery is the latency time, the time that it takes to transfer the auditory, the visual, and even the tactile feedback between 2 locations. And the acceptable delay is about 150 milliseconds. So why is latency a concern? Well, if it's 100 milliseconds or less, there's no perceivable awareness of the delay. But when you start to get to 200 to 300 milliseconds, you're very aware of it. The lag time is significant, and that obviously sets you up for more chances of critical errors. So we are in this sort of telecom revolution. We have improved networks, the latencies, times are low, we have cyber secure space, the transmissions, whether it's by fiber, satellite, or dedicated 5G now exist. There's a wider adoption of 5G networks, and we're starting to see artificial intelligence really come into play in here, and I think that as we go forward, that's going to be part of the future. So telesurgery is possible just because it's possible, and this is Dr. Patel's prostatectomy, the first prostatectomy, 85 minutes, blood loss 100 cc's, no complications. You can see the latency was less than 100 milliseconds. You know, there were no issues with the assistant, but just because we have the technology doesn't really solve the problem. Just because we can do it doesn't mean we should. And it's interesting, I was fortunate enough to be with Ralph Klayman when we did the first laparoscopic nephrectomy, and I remember saying, you know, someday I'm going to be able to wake up, go to my computer, and do surgery on a patient. And I really believe in my lifetime we've now started to see that, and this will become more commonplace. Here are the challenges. I think we talked a little bit about the technology, but I think that there's significant economic issues and insurers and investment issues. You can see that there's awareness, cultural issues, regulatory issues, but it's sort of this, telesurgery is in this sort of hype of innovation. We start to see these peaks of inflated expectations, we see these troughs of disillusionment, and then we start to see it plateau out on where we're going to be going forward. What are the other future considerations? Obviously imaging, training and technology. There are ethical considerations, you know, privacy and confidentiality, informed consent. You know, what's the competency and what are the regulations regarding training for these types of surgeons? And then there are medical legal policy considerations, you know, understanding who's liable if things go wrong. There are cultural and diversity issues and economic considerations, which we talked about previously. There is a humanitarian benefit, and I think that this is where we're starting to expand specialized care. You know, it reduces geographic disparities, it potentially can reduce costs, we can improve patient outcomes, and there is a training and educational component that telesurgery really can provide. So there is a long road ahead, and it's going to require a significant amount of cooperation with the technology, the regulations, and the privacy issues. And then implementing this is going to take some time, and you can't just rush into this. So what are the lessons learned? Well, telesurgery is safe, it's effective, and it's perceived benefit if there's less travel involved, if it can be done safely and effectively. We can train local surgeons effectively. We have the bandwidth, and we now, with the changes that we see in technology, we have the framework to work well. Practice demands evidence, and evidence establishes the practice. And there are partnerships that will exist between us. So here are the challenges, trying to make sure that we do it in a safe and regimented fashion. Latency issues, I think we've started to overcome. This is just sort of a schematic of what it potentially can look like. The workup being done, the surgeon being in a remote site, and then the patient being discharged. And this is actually all reality today. You know, Vip Patel really deserves credit for organizing the first telesurgery conference. This is a group of surgeons from all over the world that came together in Orlando about a year and a half ago to really start to look at the regulatory issues across the board. So we started to see these technology advancements in robotics. We see artificial intelligence, we're seeing miniaturization and flexibility. You know, we talked a little bit about telesurgery and teleoperations, increased automation, but really affordability and accessibility really are going to be key going forward. We know that almost 700 patents expired between 2016 and 2020 with regarding robotic systems. Here are all the different robotic systems that exist out there. You can see many of us have worked with the Da Vinci system, but you can see the Hugo now is starting to become the Hinatori system from Japan, the Dexter system from Switzerland, and you can go on and on. I think this is the system that all of us in America are used to, the Da Vinci. I remember working with the first Da Vinci, and now I'm, working with the Da Vinci 5 system, the single port system. But I think the bar is set pretty high for new robotic platforms that are not intuitive. So they have to have a speciality specific. Some of them are specifically for orthopedics. They need to be cheaper systems. They have to have good functionality, and they have to have support for training and education. So here are just a couple of them. I'm going to run through them quickly. The Hugo system. This is actually in trials in the United States. Jim Porter is doing this. It has a modular surgical arms and wheeled carts. It's an open consult. The challenges are, getting into sites. Intuitive surgical has obviously significant penetration, and it's still a work in progress, but this is being used in Europe and in Asia, and there's no US approval at this point in time. The CMR Versus, this is the Cambridge robotic system. Again, a modular system, 5 millimeter instruments. The surgeon sits in an open console with high definition glasses. Very much similar challenges to what we see with the Hugo. This is in Europe, in the United Kingdom, Asia, and Latin America. Again, not available in the United States. The Avantera, this is the German system. Again, more modular type systems. It's an open console. We're starting to see a change in the console. Instead of looking in a box, sitting upright, and this does have CE approval and is being done in Europe. The Dexter robot, this is the first hybrid robotic platform that allows you to do robotic-assisted procedures as well as laparoscopic procedures. Again, modular. It is available in Europe, and it has been done in a lot of gynecologic and urological procedures. The Hinatori, which is the Japanese system, you can see it looks very similar to what we see with the intuitive system. It has a semi-open consult, but again, this is used in Japan and in Asia. There have been a significant number of urological procedures done with this device. And then the MicroPort, this is the system that's used in China. It is available in China, Africa, and Europe. This is actually one of the telesurgery capable systems that I think you'll start to see being used with telesurgery much more commonly. And then the last one is the Sentir system. Again, it's very similar to the Da Vinci system. It does have this master save. What's different about this is these surgical instruments are reusable with this system. So I think as we look to future platforms, they need to have a reliability and functionality. They need to be financially viable and cost competitive, and there have to be training models. The new innovations really have tactile feedback or haptic feedback. You're going to be able to look at real-time imaging with augmented reality overlay, and I think that artificial intelligence will provide feedbacks, and you're going to see improved ergonomics. So I'd like to just thank Vip Patel and Jacques Mercot for providing me the videos for the presentation. Thank you very much.